Now that's going to be, I think, the premier conference on lung cancer in 2012. There's going to be a lot of new science. We're going to have a lot of results of studies, and maybe some of those will help to answer the difficulties we created with the reclassification of lung cancer with the 7th edition of TNM. So it's an exciting time. It's always a well-organized meeting, and it's a fun place to be. The TNM classification started in 1968. It was started by an international body called the International Union Against Cancer, the IASLC, and they produced the very first classification using TNM to describe the anatomical extent of cancer. At that time they had no data, and it was a consensus opinion, and they did a pretty good job. Subsequently, the American Joint Committee on Cancer Staging and End Results Reporting, called the AJC, they came up with their own TNM classification. And so clearly there were the possibilities at that time of having two different classifications governing our assessment of cancers. Lung cancer is our particular interest. And so these two organizations, the AJCC and the IASLC, collaborated, came to an agreement and said, right, we'll sort this out between us and we'll have just one classification that's applied around the world. And that was very successful. In 1978, we had the first data-driven revision, and that came from a database in the US. And it was certainly revolutionary and a great step forward. I think the problem was that from that moment on, all of the revisions came from the same database, so that it was a single institution, largely surgically treated cases, or at least cases referred for a surgical opinion. And so whilst we had an international classification, it was not based on international data, and it was not based on data which was derived from patients having all forms of treatment. And that deficiency became more and more obvious as the years went by, until 1997, when the 5th edition was published. And I think at that time it had reached the point where we felt that the IASLC had a responsibility to do something about correcting that deficiency. And so we convinced the IASLC to put up some money to create an international committee, but also back that up with an international database. And we accumulated over 100,000 cases from 46 data centers in 19 countries around the globe. So it was a massive departure from what had been going on before, but also that allowed us to do a very detailed analysis. We could do a lot of validation. So we came up with quite a marked change from previous editions. The one thing we couldn't do is that we couldn't then apply this new classification to existing databases. And we also could not suggest that from the data that we could change the treatment algorithms. So whilst some of the descriptors, the T and the M descriptors in particular, were changed, the resulting T and M stage groups for some patients were changed. We couldn't then say, well, that means that this patient should have different treatment than they had before under the old classification. And it's quite a lot of patients. It's been reckoned that 1 in 6 patients would actually now be classified in a different stage than they would have been under the previous edition. So I think we've done a very good job at giving the world a better classification, a classification that aligns prognosis with stage in a way that's never been possible before. But sadly, we have created for the lung cancer community the dilemma of undermining the treatment algorithms which have evolved over 30 years of treating millions of patients around the globe. And that is the challenge for the future. We've set this challenge to the lung cancer community. Do the studies, do the trials, find out whether indeed the treatment changes should follow the changes in stage or not. Our database and our revisions were not by any means flawless. You collect a lot of data and you think you're doing pretty well, but we have taught the world to be critical about the way TNM has evolved. And so it's quite appropriate that we ourselves get criticized. And there are criticisms because it was retrospectively collected data. It was data that was collected for all sorts of reasons, but it was not collected to inform TNM revisions. And so there are certain aspects of our recommendations which could be improved. And the IASLC recognizes those deficiencies. We're going to work very, very hard to correct them. Sadly, they can't be corrected overnight. It's going to take many revisions over decades to deal with all of these limitations. And we're proposing, indeed we are establishing, a prospective data set which is much more difficult to collect, much more expensive to collect, but the data is much more valuable. And that's where the IASLC is now. We're going beyond lung cancer. We are an organization which focuses very much on lung cancer, but we also have specialists and scientists who are looking at other thoracic malignancies such as mesothelioma, thymic cancers and various other tumors within the chest. And so we have set up subcommittees of the staging project so that when the next revision, the 8th edition, is published, and that's presently scheduled for 2016, we will be covering in our recommendations lung cancer, the biggest killer in the world, so it's going to remain our major focus, but we're also going to include recommendations for new classifications for mesothelioma, thymic malignancies, and even esophageal cancer.